Communicable chronic granulomatous disease caused by Mycobacterium tuberculosis. It usually involves the lungs but may affect any organ or tissue in the body. The World Health Organization considers tuberculosis to be the most common cause of death resulting from a single infectious agent. It is estimated that 1.7 billion individuals are infected worldwide, with 8 to 10 million new cases and 1.5 million deaths per year. In the Western world, deaths from tuberculosis peaked in 1800 and steadily declined throughout the 1800s and the 1900s. However, in 1984, the decline in new cases stopped abruptly, a change that resulted from the increased incidence of tuberculosis in HIV-infected individuals. As a consequence of intensive public health surveillance and tuberculosis prophylaxis among immunosuppressed individuals, the incidence of tuberculosis in US-born individuals has declined since 1992. In 2014, there were approximately 9,400 new cases of active tuberculosis in the United States, with nearly 60% of these occurring in immigrants from countries where tuberculosis is endemic. Tuberculosis flourishes under conditions of poverty, crowding, and chronic debilitating illness. In the United States, tuberculosis is a disease of older adults, the urban poor, patients with AIDS, and members of minority communities. African Americans, Native Americans, the Inuit from Alaska, Hispanics, and immigrants from Southeast Asia have higher rates of disease than other segments of the population. Certain disease states also increase the risk, such as diabetes mellitus, Hodgkin lymphoma, chronic lung disease, and particularly silicosis, chronic renal failure, malnutrition, alcoholism, and immunosuppression. In areas of the world where HIV infection is prevalent, HIV infection is the dominant risk factor for the development of tuberculosis. It is important that infection be differentiated from disease. Infection implies seeding of a focus with organism, which may or may not cause clinically significant tissue damage, meaning disease. Although other routes may be involved, most infections are acquired by direct person-to-person transmission of airborne droplets of organisms from an active case to a susceptible host. In most individuals, an asymptomatic focus of pulmonary infection appears that is self-limited, although uncommonly. Primary tuberculosis may result in the development of fever and pleural effusions. Generally, the only evidence of infection, if any remains, is a tiny, telltale fibrocalcific nodule at the site of the infection. Viable organisms may remain dormant in such loci for decades, and possibly for the life of the host. Such individuals are infected but do not have active disease, and therefore cannot transmit organisms to others. Yet, if their immune defenses are lowered, the infection may reactivate to produce communicable and potentially life-threatening disease. Infection with Mycobacterium tuberculosis typically leads to the development of delayed hypersensitivity, which can be detected by the tuberculin Mantoux test. About 2 to 4 weeks after the infection has begun, intracutaneous injection of 0.0 milliliters of sterile purified protein derivative PPD induces a visible and palpable induration, at least of 5 millimeters in diameter, that peaks in 48 to 72 hours. Sometimes more purified protein derivative is required to elicit the reaction, and unfortunately in some responders, the standard dose may produce a large necrotizing lesion. A positive tuberculin skin test result signifies cell-mediated hypersensitivity to tubercular antigens, but does not differentiate between infection and disease. A well-recognized limitation of this test is that false negative reactions or skin test energy may be produced by certain viral infections, sarcoidosis, malnutrition, Hodgkin lymphoma, immunosuppression, and notably overwhelming active tuberculosis disease. False positive reactions may result from infection by atypical mycobacteria. About 80% of the population in certain Asian and African countries is tuberculin positive. In contrast, in 2012, approximately 5% to 10% of the US population was positive, indicating the marked difference in rates of exposure to the tubercle bacillus. In general, 3 to 4% of previously unexposed individuals acquire active tuberculosis during the first year after tuberculin conversion, and no more than 15% do so thereafter. Therefore, only a small fraction of those who contract an infection develop active disease. Mycobacteria are slender rods that are acid-fast, meaning they have a high content of complex lipids that readily bind the Ziehl-Neelsen stain and subsequently stubbornly resist decolorization. Mycobacteria tuberculosis hominis, shown on the picture, is responsible for most cases of tuberculosis. The reservoir of infection typically is found in individuals with active pulmonary disease. Transmission usually is direct by inhalation of airborne organisms in aerosols generated by expectoration or by exposure to contaminated secretions of infected individuals. Oropharyngeal and intestinal tuberculosis contracted by drinking milk contaminated with Mycobacterium bovis infection is now rare except in those countries with tuberculous dairy cows and sales of unpasteurized milk. Other mycobacteria, particularly Mycobacterium avium complex, are much less virulent than Mycobacterium tuberculosis and rarely cause disease in immunocompetent individuals. However, they cause disease in 10 to 30% of patients with AIDS. The pathogenesis of tuberculosis in the previously unexposed immunocompetent individual is centered on the development of cell-mediated immunity, which confers resistance to the organism and results in development of tissue hypersensitivity to tubercular antigens. The pathologic features of tuberculosis, such as caseating, granulomas, and cavitation, are the result of the destructive tissue hypersensitivity that is part and parcel of host immune response. Because the effector cells for both protective immunity and damaging hypersensitivity are the same, the appearance of tissue hypersensitivity also signals the acquisition of immunity to the organism. The sequence of events from inhalation of the infectious inoculum to containment of the primary focus can be outlined as follows: entry into macrophages, followed by replication in macrophages, followed by development of cell-mediated immunity, followed by T-cell-mediated macrophage activation and killing of bacteria, followed by granulomatous inflammation and tissue damage. A virulent strain of Mycobacteria gains entry to macrophage endosomes, a process mediated by several macrophage receptors, including the macrophage mannose receptor and complement receptors that recognize several components of the mycobacterial cell walls. Once internalized, the organisms inhibit normal microbicidal responses by preventing the fusion of the lysosomes with phagocytic vacuole, allowing the mycobacterium to persist and proliferate. Therefore, the earliest phase of primary tuberculosis, the first 3 weeks, in the non-sensitized patient, is characterized by bacillary proliferation within the pulmonary alveolar macrophages and air spaces, eventually resulting in bacteremia and seeding of the organisms to multiple sites. Despite the bacteremia, most individuals at this stage are asymptomatic or have mild flu-like illness. Development of cell-mediated immunity occurs approximately 3 weeks after exposure. Processed mycobacterial antigens reach the draining lymph nodes and are presented to CD4 T cells by dendritic cells and macrophages. Under the influence of macrophage-secreted interleukin-12, CD4 plus T cells of the Th1 subset are generated that are capable of secreting interferon gamma. Interferon gamma released by the CD4 plus T cells of the Th1 subset is crucial in activating macrophages. Activated macrophages in turn release a variety of mediators and upregulate expression of genes with important downstream effects, including tumor necrosis factor, which is responsible for recruitment of monocytes, which in turn undergo activation and differentiation into the epithelioid histiocytes that characterize the granulomatous response. Inducible nitric oxide synthase, which raises nitric oxide levels, helping to create reactive nitrogen intermediates that appear to be particularly important in killing of mycobacteria, and antimicrobial peptides that are also toxic to mycobacterial organisms. In addition to stimulating macrophages to kill mycobacteria, the Th1 response orchestrates the formation of granulomas and caseous necrosis. Macrophage activated by interferon gamma differentiate into the epithelioid histiocytes that aggregate to form granulomas. Some epithelioid cells may fuse to form giant cells. In many individuals, this response halts the infection before significant tissue destruction or illness occur. In other individuals with immune deficits due to age or immunosuppression, the infection progresses and the ongoing immune response results in caseation necrosis. Activated macrophages also secrete tumor necrosis factor and chemokines, which promote recruitment of more monocytes. The importance of tumor necrosis factor is underscored by the fact that patients with rheumatoid arthritis who are treated with a tumor necrosis factor antagonist have an increased risk for tuberculosis reactivation. In summary, immunity to a tubercular infection is primarily mediated by Th1 cells, which stimulate macrophages to kill mycobacteria. This immune response, which is largely effective, comes at the cost of hypersensitivity and the accompanying tissue destruction. Defects in any of the steps of a Th1 T cell response, including interleukin-12, interferon gamma, tumor necrosis factor, or nitric oxide production, result in poorly formed granulomas, absence of resistance, and disease progression. Individuals with inherited mutations in any component of the Th1 pathway are extremely susceptible to infections for mycobacteria. Reactivation of the infection or re-exposure to the bacilli in a previously sensitized host results in rapid mobilization of a defensive reaction but also increased tissue necrosis. Just as hypersensitivity and resistance appear in parallel, so too the loss of hypersensitivity indicated by tuberculin negativity in a mycobacterial tuberculosis infected patient. This is an ominous sign of fading resistance to the organism. Primary tuberculosis is a form of disease that develops in a previously unexposed and therefore unsensitized patient. About 5% of those newly infected acquire significant disease. In the large majority of otherwise healthy individuals, the only consequence of primary tuberculosis are the foci of scarring discussed earlier. However, this foci may harbor viable bacilli and therefore serve as a nidus for disease reactivation at a later time if host defenses wane. Uncommonly, new infection leads to progressive primary tuberculosis. This complication occurs in patients who are overtly immunocompromised or who have more subtle defects in host defenses, as is characteristic of malnourished individuals. Certain racial groups, such as the Inuit, also are more prone to the development of progressive primary tuberculosis. The incidence of progressive primary tuberculosis is particularly high in HIV-positive patients with significant immunosuppression. Immunosuppression results in an inability to mount a CD4 plus T-cell mediated response that would contain the primary focus. Because hypersensitivity and resistance are more often concomitant factors, the lack of a tissue hypersensitivity reaction results in the absence of the characteristic caseating granulomas, so known as non-reactive tuberculosis. In countries in which bovine tuberculosis and infected milk have largely disappeared, primary tuberculosis almost always begins in the lungs. The inhaled bacilli usually implant in the distant air spaces of the lower part of the upper lobe or in the upper part of the lower lobe. They are typically close to pleura. During the development of sensitization, a 1 cm to 1.5 cm area of gray-white inflammatory consolidation emerges. This is called the gone focus, shown on the picture by the arrows. In majority of cases, the center of this focus undergoes caseous necrosis, shown by the arrow on the picture. Tubercle bacilli, either free or within phagocytes, travel via lymphatic vessels to the regional lymph nodes, which also often caseate. This is shown by the stars, black stars. This combination of parenchymal and nodal lesions is called the Gone complex. Lymphatic and hematogenous dissemination to other parts of the body also occurs during the first few weeks. Development of cell-mediated immunity controls the infection in approximately 95% of cases. Therefore, the Gone complex undergoes progressive fibrosis, and calcification often follows, detectable as a Ranke complex on radiograph. In the picture you see mildly calcified right hilar lymph node, arrowhead, and tuberculoma, and lymph node is shown by the arrowhead, and tuberculoma is shown by the arrow, which manifests as a solitary round pulmonary lesion in a child with tuberculosis. Despite seeding of the organs, no lesion develop. Histologically, sites of infection are involved by a characteristic inflammatory reaction marked by the presence of caseating and non-caseating granulomas, which consist of epithelioid histiocytes and multinucleate giant cells. The caseating granuloma is shown on the left, and non-caseating is shown on the right. Secondary tuberculosis is the pattern of a disease that arises in a previously sensitized host. It may appear shortly after primary tuberculosis, but more commonly arises from reactivation of dormant primary lesions many decades after initial infection, particularly when host resistance is weakened. It also may result from reinfection, which may occur either because the protection afforded by the primary disease has waned or because of exposure to a large inoculum of virulent bacilli. Whatever the source of the organism, only a few patients, less than 5%, with primary disease subsequently develop secondary tuberculosis. Secondary pulmonary tuberculosis is classically localized to the apex of one or both upper lobes. You see the one lobe on the picture. The reason is obscure but may relate to high oxygen tension in the apices. Because of the pre-existence of hypersensitivity, the bacilli excite a prompt and marked tissue response that tends to wall off the focus. As a result of this localization, the regional lymph nodes are less prominently involved early in the disease than they are in primary tuberculosis. On the other hand, cavitation occurs readily in the secondary form, leading to erosion into and dissemination along airways. Such changes become an important source of ineffectivity because the patient now produces sputum containing bacilli. Secondary tuberculosis should always be an important consideration in HIV-positive patients who present with pulmonary disease. Of note, although an increased risk for tuberculosis exists at all stages of HIV disease, the manifestations differ depending on the degree of immunosuppression. For example, patients with less severe immunosuppression present with the usual secondary tuberculosis with apical disease with cavitation, while those with more advanced immunosuppression present with a clinical picture that resembles progressive primary tuberculosis with lower and middle lobe consolidation, hilar lymphadenopathy, and non-cavitary disease. The extent of immunosuppression also determines the frequency of extrapulmonary involvement, rising from 10 to 15% in mildly immunosuppressed patients to greater than 50% in those who have severe immune deficiency. The initial lesion usually is a small focus of consolidation, less than 2 cm in diameter, shown by the arrow on the picture, with 1 to 2 centimeters of the apical pleura. Such foci are sharply circumscribed, firm gray-white to yellow areas that have a variable amount of central caseation and peripheral fibrosis. In favorable cases, the initial parenchymal focus undergoes progressive fibrous encapsulation, leaving only fibrocalcific scars. Histologically, the active lesions show characteristic coalescent tubercles with central caseation. Although tubercle bacilli can be demonstrated by appropriate methods in early exudative and caseous phases of granuloma formation, it is usually impossible to find them in the late fibrocalcific stages. Localized apical secondary pulmonary tuberculosis may heal with fibrosis either spontaneously or after therapy, or the disease may progress and extend along several different pathways. In progressive pulmonary tuberculosis, the apical lesion enlarges and the area of caseation expands. Erosion into a bronchus evacuates the caseous center, creating a ragged, irregular cavity lined by caseous material that is poorly walled off by fibrous tissue, shown on the picture by a red arrow. Erosion of blood vessels results in hemoptysis. With adequate treatment, the process may be arrested, although healing by fibrosis often distorts the pulmonary architecture. Irregular cavities now free of caseous necrosis may remain intact or collapse and become fibrotic. If the treatment is inadequate or host defenses are impaired, the infection may spread by direct extension and by dissemination through airways, lymphatic channels, and the vascular system. Miliary pulmonary disease occurs when organisms reach the bloodstream through lymphatic vessels and then recirculate to the lung via the pulmonary arteries. The lesions appear as small foci of yellow-white consolidation scattered through the lung parenchyma. The word miliary is derived from the resemblance of this foci to millet seeds. With progressive pulmonary tuberculosis, the pleural cavity is invariably involved, and serous pleural effusions, tuberculous empyema, or obliterative fibrous pleuritis may develop. Endobronchial, endotracheal, and laryngeal tuberculosis may develop when infective material is spread either through lymphatic channels or from expectorated infectious material. The mucosal lining may be studded with minute granulomatous lesions, sometimes apparent only on microscopic examination. Systemic miliary tuberculosis ensues when the organisms disseminate hematogenously through the body. Systemic miliary tuberculosis is most prominent in the liver, bone marrow, spleen, adrenal glands, brain, meninges, kidneys, fallopian tubes, and epididymis. Isolated organ tuberculosis may appear in one of the organs or tissues seated hematogenously and may be the presenting manifestation of tuberculosis. Organs typically involved include the meninges, tuberculous meningitis, kidneys, renal tuberculosis, adrenal glands, bones, osteomyelitis, and fallopian tubes, Sapargalieva. On the left picture, you see caseous meningoencephalitis, typically unevenly distributed, dense, gelatinous, fibrinous cellular leptomeningeal exudates located in the interpendicular fossa. The exudate spreads anteriorly, encircling the optic chiasma and anterior cerebral vessels, and laterally deep into the sylvian fissures, almost wrapping the carotid middle cerebral trunks and their penetrating branches. Caudally, the exudate covers the pontomesencephalic, medullary, and cerebral cisterns, thereby blocking the foramen of Luschka. On the right, in the top part, you see granulomatous proliferative meningitis in case of tuberculous meningitis. On the right, in the bottom, you see tuberculous necrotizing vasculitis. On the left picture, you see two fossae of caseous necrosis in the upper pole, shown by the arrows. On the right picture, the focal caseating granulomas, shown by the arrows, and sheets of chronic interstitial inflammation, shown by the arrowhead. On the picture on the left, you see left adrenal gland of the patient showing a well-defined gray-whitish firm nodule with multi-fossae caseous necrosis. On the right picture is a granulomatous inflammation with caseous necrosis and Langerhans type giant cells. Inset is a high-power view of the caseous necrotic areas showing an acid-fast stain positive bacillus. On the picture on the left is a tuberculous osteomyelitis on right wrist. This is a view of plain radiograph of the right wrist, revealed a lytic lesion with soft tissue swelling, suspected diagnosis of giant cell tumor. On the right picture is tuberculous osteomyelitis with infiltration that includes giant cells, shown by the arrows, and lymphocytes without malignant cells. On the picture on the left is hysterosalpingography, is a method for examination in suggesting genital tuberculosis. You see irregular borders and beaded appearance noted in both the fallopian tubes, with obstruction at distal isthmic portion with golf club appearance. On the right picture, in the fallopian tubes, you see granulomas, shown by the arrows. Lymphadenitis is the most frequent form of extrapulmonary tuberculosis, usually occurring in the cervical region. Lymphadenopathy tends to be unifocal, and most patients do not have concurrent extranodal disease. HIV-positive patients, on the other hand, almost always have multifocal disease, systemic symptoms, and either pulmonary or other organ involvement by active tuberculosis. In the past years, intestinal tuberculosis contracted by the drinking of contaminated milk was fairly common as a primary focus of tuberculosis. In developed countries today, intestinal tuberculosis is more often a complication of protracted advanced secondary tuberculosis, secondary to the swallowing of coughed up ineffective material. Typically, organisms are trapped in mucosal lymphoid aggregates of the small and large bowel, which then undergo inflammatory enlargement with ulceration of the overlying mucosa, particularly in the ileum. On the picture you see an ulcer with irregular indurated borders in ileum. Localized secondary tuberculosis may be asymptomatic. When manifestation appears, they are usually insidious in onset with gradual development of both systemic and localizing symptoms and signs. Systemic manifestations, probably related to the release of cytokines by activated macrophages, often appear early in the disease course and include malaise, anorexia, weight loss, and fever. Commonly, the fever is low-grade and remittent, and night sweats occur. With progressive pulmonary involvement, increasing amounts of sputum, at first mucoid and later purulent, appear. When cavitation is present, the sputum contains tubercle bacilli. Some degree of hemoptysis is present in about half of all cases of pulmonary tuberculosis. Pleuritic pain may result from extension of the infection to the pleural surfaces. Extrapulmonary manifestations of tuberculosis are legion and depend on the organ system involved. For example, tuberculous salpingitis may present as infertility, tuberculous meningitis with headache and neurological deficits, port disease with back pain and paraplegia. The diagnosis of pulmonary disease is based in part on the history and on physical and radiographic findings of consolidation or cavitation in the apices of the lens, shown on the left picture by the arrow. Ultimately, however, tubercle bacilli must be identified, as shown on the picture on the right. The most common methodology for diagnosis of tuberculosis remains demonstration of acid-fast organisms in sputum by staining or by use of fluorescent auramine rhodamine. Conventional cultures for mycobacteria require up to 10 weeks, but liquid media-based radiometric assays that detect mycobacterial metabolism are able to provide an answer within 2 weeks. Polymerase chain reaction amplification can be performed on liquid media with growth as well as on tissue sections to identify the mycobacterium. However, culture remains the standard diagnostic modality because it can identify the occasional polymerase chain reaction negative case and also allows testing of drug susceptibility. On the picture you see polymerase chain reaction amplification products obtained by panel A, which differentiates Mycobacteria tuberculosis from all other mycobacterial species, including the ones like Mycobacteria bovis that belong to Mycobacteria tuberculosis complex. Of concern, multi-drug resistant tuberculosis, defined as resistance of mycobacteria to 2 or more of the primary drugs used for treatment of tuberculosis. It is becoming more common, and the World Health Organization estimated that 500,000 individuals were newly infected with multi-drug resistant tuberculosis in 2014. This represents approximately 3% of new cases and 20% of previously treated cases. The epicenter of this troubling epidemic lies in Eastern Europe and post-Soviet countries, where in some locales up to 20% of new infections are with multi-drug resistant strains. Of even greater concern, approximately 5 to 10% of such cases exhibit extensive multi-drug resistance, defined by resistance to a broad spectrum of antibiotics and current use against tuberculosis. The prognosis is determined by the extent of the infection, localized versus widespread, the immune status of the host, and the antibiotic sensitivity of the organism. Understandably, the prognosis is guarded in those with multi-drug resistant tuberculosis. Amyloidosis may develop in persistent cases. In summary, it should be said that tuberculosis is a chronic granulomatous disease caused by Mycobacterium tuberculosis, usually affecting the lungs, but virtually any extrapulmonary organ can be involved. Initial exposure to mycobacteria results in development of a cellular immune response that confers resistance and leads to hypersensitivity as determined by positive results on the tuberculin skin test. The Th1 subset of CD4 plus T cells have a crucial role in cell-mediated immunity against mycobacteria. Mediators of inflammation and bacterial containment include interferon gamma, tumor necrosis factor, and nitric oxide. The histopathologic hallmark of host reaction to tuberculosis in immunocompetent individuals is the presence of granulomas, usually with caseous necrosis. Primary pulmonary tuberculosis in immunocompetent individuals is asymptomatic and results only in healed lesions, typically in a subpleural focus and a draining lymph node. Secondary reactivation tuberculosis arises in previously exposed individuals when host immune defenses are compromised and usually manifests as a cavitary lesion in the lung apices. Both progressive primary tuberculosis and secondary tuberculosis can result in systemic seeding, causing life-threatening forms of disease such as miliary tuberculosis and tuberculous meningitis. HIV seropositive status is an important risk factor for the development or recrudescence of active tuberculosis. Thank you for your attention.